This is the story of Snow White and the Runaway Bride. Sometimes, when all was going on well, the bride, dressed in white, may decide to change directions and run away. We all aim and desire for a free-floating flap in a Snow White cataract, as in this femtolaser-assisted case. In this case, after a good staining time with trypan blue, rhexis was initiated and the fluid from under the flap was aspirated. But this white cataract was not so soft. The rhexis suddenly extended at the 10:30 o'clock and then at 5 o'clock. Another side pot was made at the 7 o'clock to give a tangential cut, and a semicircular rhexis was fashioned. Similar was done for the other side. Phacoemulsification was started and a hemisphere of the nucleus was pulled out to the iris plane to minimize intra-bag manipulation. Intraoperative pressure was kept as low as 30 during the phacoemulsification. Always keep an eye on the flap motility sign. The torn rhexis margins were everted and fluttering, denoting a pre-equatorial extension. Viscoelastics were always given before taking out the phaco probe or the bimanual cannulas. IOL haptics were placed perpendicular to the extension. This patient had a history of recurrent uveitis. All was going on well, but when you think of taking the bride for granted, that is when she decides to run away. Viscoelastics should be injected at the site of extension. I tried retrieving the rhexis with microrhexis forceps, but to no avail. Ultimately, microscissors was used to fashion the rhexis from the other side. Phacoemulsification was thereby completed, keeping an eye on the flap motility sign, and IOL implanted. In this case, after a good staining of the anterior capsule, a complete rhexis was achieved. After a few chops, complete separation of the pieces at the center was checked with the help of two Sinskey hooks. But as I took out the first quadrant, which was relatively larger, the intact rhexis margin gave way. Phacoemulsification was completed, keeping an eye on the flap motility sign. Since the tear was opposite to the main wound, I changed gears from temporal to superior for the implantation of the IOL. Well, this Snow White cataract was a little shy and iris hooks were placed. During rhexis, slight zonular weakness was encountered and the vector forces were accordingly adjusted. Using microrhexis forceps scores over cystitome, as the support is usually soft and fluffy in a white cataract. Bimanual dexterity is important, as doing rhexis from the opposite port helps us make the best use of vector forces. Rhexis achieved here was small oval and slightly paracentral. Phacoemulsification was done and IOL implanted. Since the rhexis was slightly paracentral, to prevent late postoperative IOL decentration, a central rhexis was refashioned. Iris hooks were removed. This patient had a kyphosis of almost 40 degrees in the maximum extended posture, in spite of putting 3 pillows under the head and 4 pillows under the hip. The corneal plane was still not at 180 degrees. Upper limbus was not fully exposed, making the left hand manipulation furthermore difficult. Capsulorhexis was completed uneventfully. Since the pupil was irregularly dilated and the patient uncooperative, I decided to put in iris hooks. Phacoemulsification was then started. All was going uneventful, but emulsification of the last piece revealed an underlying small roundish central posterior capsular defect. Phacoemulsification was completed and viscoelastics given before withdrawal of the phaco probe. Multipiece IOL was implanted and optic capture done. Well, this was the story of Snow White and the Runaway Bride. Thank you.